invite both of our speakers up and open up the microphones while Dr. Sultani is coming up. Maybe I'll just start with Mark. So I thought the abstract, I think it was a retrospective analysis of some kind of administrative data set that purported to show that gastroparesis was common in obesity was interesting. And I think it may speak to something you alluded to earlier, which is you have to be very careful about who you call gastroparesis. Because in our emergency room, everybody who has nausea and vomiting and is getting an opioid because of abdominal pain has gastroparesis, whether they get a gastric emptying study or not. So I think in administrative data sets, it's throwing things off. And I thought that also the fact that the people who had more severe comorbidity were the non-obese, those may be actually the people who have gastroparesis. Any thoughts on that?
Yeah, I mean, what's changed with gastroparesis for the better is that we used to do the 90-minute gastric emptying test. PPI will make the gastric emptying test in 90 minutes delayed because PPI is delayed trituration and other things. So many things could affect 90 minutes. Less things affect the 4-hour gastric emptying test. But here's the problem, as you mentioned, in the ER. As soon as the ER says, believe it's gastroparesis, and that ends up in the chart, the residents label the patient as gastroparesis forever. And, you know, UTIs, so many things can delay gastric emptying, cause nausea and vomiting. It's really unfortunate when they get labeled, and we try and strip the label back off because that doesn't do the patient any service if it's the wrong care.
Yeah, totally agree. Sasan.
2 quick questions. One, in terms of the achalasia type 1 and 2, I've not done a balloon dilation now in 20 years. Should we start buying those balloons and using 30 and 35 in private practice and community, or would you advocate, again, using POEM, since that seems to be taken off on a lot of these cases? We have local folks that do it, but sometimes hard to get into the tertiary center for referral. So would you advocate balloon for a year or 2? Would that affect POEM in the future in terms of making it more difficult and such? And in terms of gastroparesis, if the panel has any, our access in terms of getting, implants or doing other type of therapy or doing flip is somewhat restricted. What's the medical approach from the panel in terms of what first medication, second, even off-label use, et cetera?
So I'll take the achalasia part. In 2022, you want to personalize management of achalasia. So there are 2 aspects to my answer to your question. First, you want to personalize management of achalasia. The spastic achalasia is a POEM. I wouldn't even mess with any other treatment. That's POEM. You tailor the POEM to the length of the spastic segment. So that's the spastic achalasia. In the non-spastic achalasia, you can actually read between the lines from the data that is available to date, including older data. So pneumatic dilation is most successful if the resting tone of the LES is not super high. So if you're working against a very high tone, you're going to need to really tear the LES. Those patients, you have better options. You have helomyotomy, you have POEM these days. So the best patient for a pneumatic dilation is going to be an older woman or an older patient in general. Women do better with pneumatic dilations than men do. If there is a contracting segment upstream of the area that you're going to try and tear, those are the patients who might end up with a perforation, because when you distend the balloon, the esophagus will just start clamping down on the balloon. And those are the ones that can have a perforation. So tailor management of achalasia to the pattern on manometry. If they're partial, if they empty partially, you can get them there with a pneumatic dilation. That's much less disruptive to the patient's life than going in for a surgery or going in for a POEM. But POEM is extremely effective. And you saw that POEM if you have that availability. So that is the second part of my answer to your question. The rate of complication with pneumatic dilation is directly proportional to the number that you do every year. So if you're going to dust off your Rigiflex balloons you haven't used for 20 years, my answer to that is don't. Because it's expertise and experience that reduces the morbidity of pneumatic dilation.
Yeah, for the gastric stimulator, I have to say that our center has taken more out than we've put in the last 5 years. What happened in the early days of gastric stimulators, people were almost using it as a business opportunity, putting them in and anybody with gastroparesis. And this became a problem that we had to deal with. So the one example is, and I put the constipation up there because we had one example of a person with delayed gastric emptying vomiting who had bowel movements once every 2 weeks. They put a stimulator in, we took it out, we took the colon out, and she's fine. She's gone to college and she's doing well. But the point is, it's not a fix all. You have to select your patients correctly. So making sure you send them to expert centers who know how to diagnose gastroparesis correctly is key.
Can I add a quick comment to that? I think when you order a gastric emptying study, you have to have an idea in your mind. What are you going to do if it's abnormal? What are you going to do if it's normal? What are you going to do if it is equivocal? If you don't have the answer to that question, don't do the study because you get confusing information. That's number one. Number two, the consortium published data saying that at 1 year, 1/3 to 40% of these gastric emptying study conclusions reverse completely. So a delayed emptying becomes normal, normal emptying becomes delayed. So it isn't totally a good test to segregate patients with gastroparesis and no gastroparesis without the symptom part. And one gastric emptying study may not be enough to really designate somebody.
That's absolutely right. And what I teach the fellows is I say the gastric emptying test you did on that patient yesterday is their gastric emptying on June 10th, but it's not their gastric emptying on June 12th. Because so many factors are involved. If they have sepsis, it can affect gastric emptying. So many factors that can affect gastric emptying that it's a moment in time, and it has to be partnered with the chronic clinical story, not just the acute clinical story.
Dr. Nguyen.
Prakash, just questions for you. Regarding that left device, do you find that with that data, will you counsel patients to now sleep on their left side as opposed to what we used to say, or we still do say, elevate the head of the bed, which is often difficult for our patients?
So their data seems to suggest that if the patient can be forced to sleep on a position other than right, that they do better. Now, will that change everything else you do for the patient? Probably no. But is this something else you can offer the patient? Maybe. There doesn't seem to be any other way to correct a patient's posture other than to wake them up and condition them using that device, at least according to Ariane Brandenburg.
Perhaps a spouse.
Well, Punjabis would always say you should sleep on the left side so you keep your sword hand free. So then you won't have reflux either. So it's a good thing.
One other thing I do want, you can't have a full stomach and do that, because all the food will sit in the fundus, and that can cause TLESRs and other things. And that food will sit there all night if you're on your left side all night. So I don't know if in the study they said make sure it's 2 or 3 hours after a meal, but I would imagine you'd have to.
They did that.
Yeah.
I thought the other abstract that was interesting and a little counterintuitive was peppermint oil for reflux symptoms. So who would you suggest that to? And what do you think the mechanism is in terms of CNS or peripheral nerve effects?
Well, it actually has been used for esophageal symptoms before. It can make some people's reflux symptoms worse, but not every symptom that a patient reports in the chest is reflux. And I think that's where the importance lies. There is old data from the 80s and 90s suggesting that if you gave somebody with chest pain and rapid transmission, so simultaneous contractions, peppermint oil, that rapidity of contraction actually improves. And some patients improve symptoms, although in that study, there was no significant symptom improvement. There are other studies that show that perceptive foregut symptoms, that includes the esophagus too, can improve with peppermint oil. But this is just like the story with digestive enzymes and probiotics. If the patient says they are better, tell them it's worth spending money on this. If they say I'm worse, toss, don't continue to use it. And iberogast is another option. It's a liquid. The dose is 1 ml 2 or 3 times a day. It can be mixed with whatever they like to drink. And for people who say, I don't like the capsules, it makes me burp, iberogast does not have that very strong pepperminty taste or feel.
Kevin.
The study on the left device is very interesting. Do you know if they looked at side effects such as daytime sleepiness? In other words, if you're getting stimulated several times during the night, does that make you sleepy during the day?
You know, they did not report that, but the intent of the device is for training. And so once the person gets used to sleeping mostly on the right, on the left side, then the idea is maybe you don't need the device, you'll just condition yourself to sleep on the left side. At least that's what their data is trying to show. Although the duration of that conditioning, whether there is a loss of that conditioning, they have not studied.
Okay, are any questions on the chat? Okay, well, thank you both for a great session.